Assalamualaikum and hi everyone. So we will continue our topic in drug-induced disorders with the second topic, which is drug-induced liver injury. So by the end of this lecture, you should be able to identify the types of drug-induced liver injury, how to manage this event or this ADR whenever it happens, and also the monitoring parameters that you can do. So approximately 20 to 30% of acute liver injury are actually associated with the use of medication, and generally it can either be dose related or dose dependent, or it is idiosyncratic, which is not depending on the. And the risk factors to develop this drug-induced liver injury may include pre-existing liver disease. So if the patient already have a previous history of liver disease, then they might have a higher risk to develop this liver injury whenever they use any drug that might cause this event or this ADR. Age is also a factor in which older age has a higher risk to develop this ADR. For example, and also pediatric, they might also have a higher risk of valproic acid hepatotoxicity. And the genetics factor is also one of the important risk factor to develop a liver injury, because particularly we are looking at the effect of hypersensitivity, in which a certain patient have a genetic factor for being hypersensitive to certain medication. They might develop an event. They might develop an ADR which is not developed by others. Also, also related to genetic is the fast or slow acetylators for isoniazide. So the slow acetylators have an increased risk for isoniazide toxicity. Also, enzyme inducers of rifampicin, for example, it may induce hepatotoxicity of other drugs like paracetamol or isoniazide. So concomitant drug use is also one of the factors in which the combination of drugs that are both affecting the liver is going to increase the risk of hepatotoxicity. And concurrent diseases like diabetes and renal disease might also affect the ability of the liver to metabolize the drug effectively. And in terms of the etiology or the development of this ADR, the type of hepatotoxic effect can be divided into two, whether it's cytotoxic or cholestatic. So cytotoxic is related to the disruption of the cell in the liver, and it can either be causing cell death, which is necrotic, or steatic, which is causing a fatty liver. And cholestatic is when there is an obstruction to the flow of the bile in the liver, so there is an impairment in the bile flow. So different medication is showing different types of liver injury. For the types of drug-induced liver injury, we have several types here, but we are just going to have a look, not that much detail for each type, and we will look at some of the examples of drugs that might cause for each type of the DILI. The first is the central lobular necrosis, in which most injuries might occur within 1 year of initiating the drug, and it is when the liver cell is undergoing destruction, and it is often dose related, and it is a predictable reaction for certain medication. Clinical presentation that you can see in the patient is that the reaction can be mild, so the patient might not get any symptoms, but there is an elevation in serum aminotransferase like AST or ALT. And in severe reactions, the patient might get nausea and vomiting, and malaise, lethargy, and they can have abdominal pain, and they can become jaundice. And there is a markedly elevated ALT to several fold. and there is a prolonged prothrombin time. So complications that might occur when the patient have this necrosis is that they can also have hypoglycemia, metabolic acidosis, bleeding, and hepatic encephalopathy. So the example of this reaction is in paracetamol poisoning, when the paracetamol was taken in overdose, like around 10 to 15 gram, and there is an excess, then there was a, and there is an excess toxic metabolites that will attack the hepatocyte, and after a few hours of ingestion, the patient might have mild symptoms of nausea and vomiting, and after a few hours they will have that elevation in liver enzymes. So the general management of paracetamol poisoning is gastric lavage if the ingestion occurs within 4 hours, or we can also use activated charcoal. And we need to measure serum concentration of paracetamol, and we can administer antidote of N-acetylcysteine to replenish the liver cells. And the most effective of this drug or this antidote is within 8 hours, but it can also give protective effect to the liver up to 24 hours after the ingestion. So the next type is steatosis, or fatty liver. So the patient might have nausea, vomiting, hypoglycemia, or confusions when they have this kind of this type of DILI, and they might also have increase in ALT level. The complication includes acidosis and jaundice in several cases. So the drugs that might cause this type of liver injury are aspirin, tetracycline, valproic acid, or amiodarone. The third type is phospholipidosis. So it happens when there is an accumulation of phospholipids at the liver cells instead of fatty acids. So it develops when the patient is taking that medication for more than 1 year. So it is an accumulative effect. The clinical presentation might be elevated in the liver enzymes and also hepatomegaly. So the drug associated with this type of reaction is usually amiodarone at high doses. So the next type is cholestasis. I mentioned before, it is it occurs when there is an obstruction to the bile duct, and some medication might injure or the bile duct and cause this obstruction. So it results in the retention of bile acid. It can be acute or chronic, in which acute it can be presented with hepatitis or with bile duct injury. But in chronic disorders, the patient might have cholelithiasis. But in chronic disorders, the patient might also have this kind of presentation as well, sclerosing cholangitis or cholelithiasis. The clinical presentation when patients having this type of reaction are nausea, malaise, jaundice, pruritus, also elevation in ALP, and chlorpromazine, amoxicillin, clavulanic acid, or carbamazepine. So note that in this obstruction type of DILI, there is an elevation in ALP, but in the necrosis, we can see elevation mostly in AST and ALT. Canalicular cholestasis, also part of cholestasis, it is associated with long-term use of high-dose estrogen. So the patient might have mild to moderate elevations of serum bilirubin. The next type is acute hepatitis. The patient might have nausea, vomiting, dark urine, pale stools, or jaundice, and there is an increase in LFT, liver function test levels, and prothrombin time. And this elevation in prothrombin time might indicate the severity of the hepatitis. And the drugs implicated with this type of reaction are isoniazid and phenytoin. Toxic cirrhosis. So cirrhosis happens when the patient is having a scar from the previous hepatitis, and it leads to the development of cirrhosis. And when it is not treated early, the hepatitis might lead to development of cirrhosis. So clinical presentation might be hepatomegaly, ascites, which is the accumulation of fluid, and also portal hypertension. Example of drug that might cause this reaction is methotrexate, and the lesion might result from the action of the bioactivated metabolite of methotrexate. So the damage or the risk of having this effect might be reduced or controlled by increasing the dosage interval to once weekly, or with the use of folic acid supplementation. So usually you can see the dosage regimen for methotrexate is once weekly, or whenever patient was given methotrexate, you can see some of them, or you can see some patients on methotrexate, they're also being given folic acid supplement. Liver vascular disorders, when there is, this is when there is, so this is when the patient having a focal lesion in hepatic venules, sinusoids, or portal veins. So it does not affect the liver cell itself, but it affects the vascular system around the liver. For example, fountain vein thrombosis or veno-occlusive disease. So this condition often followed by necrosis and can result in cirrhosis later. The clinical presentation is abdominal pain, ascites, jaundice, and upper GI bleeding. So these are the drugs that might cause these vascular disorders. So these are the list of examples of those related drug-induced hepatotoxicity. As we have discussed before, paracetamol with a single dose of more than 10 grams, tetracycline with a dose of more than 2 grams daily, methotrexate with a weekly dose of more than 15 grams, or cumulative dose of more than 2 grams in 3 years. Also salicylates like aspirin, chronic use of more than 2 grams daily might also cause a hepatotoxicity. So just a little bit about the mechanism of DILI. It can either be through autoimmunity or the idiosyncratic reactions. So for autoimmunity, it involves the antibody-mediated cytotoxicity, or there can also be a direct cellular toxicity. So it basically involves the production of neoantigens, in which it will cause a cytotoxic attack by T cells. So the example of drugs that have this mechanism is sulfamethoxazole, carbamazepine, or nevirapine. For idiosyncratic reactions, it is less predictable and it is quite rare. It can be categorized into allergic reaction or non-allergic reaction. For allergic reaction, it is usually dose-related. People might have, and the patient might have fever, rash, eosinophilia, and it can occur within a short period of the initiation of the drug. Like the example drug is nitrofurantoin and phenytoin. For non-allergic reaction, it can take a longer time before it can develop, like the use of long-term amiodarone, isoniazid, or ketoconazole. So you need to do a drug assessment first when you suspect that your patient is having hepatotoxicity due to the drug. So in this case, you might need to rule out any use of recreational drugs like cocaine or ecstasy, in which might also cause some level of hepatic injury or hepatotoxicity. And also assess the use of non-drug, in which is also going to cause hepatic injury, like occupational hazards. For example, if the patient is working in a factory that might expose him to any chemical or hazards like arsenic or any other dangerous compounds. Also the use of alternative medicine. As we know, some of the herbal medicines are not standardized, and some of them might have taking it in a large dose. It might cause accumulation in the liver and might also affect the liver condition, and also viral hepatitis. And we also need to identify other precipitating factors in this patient to identify whether this patient is initially at a high risk to develop this hepatotoxicity. The first is the nutrition status of the patient, whether the patient is having malnutrition due to long-term illness or due to lower nutritional intake, and also if the patient have high levels of vitamin E, vitamin C, or serum iron that might cause or interfere with the liver enzyme levels. So these are the so this is the schematic diagram of the workflow that you need to do whenever you want to do an assessment of drug-induced liver disease. For example, your patient comes in with jaundice, so you want to consider drugs that might cause jaundice that the patient is taking, any relevant drug history, any OTC, any illicit drug use, herbal preparation, and vitamins, and whether this patient also having rash, and also if there is no other cause of jaundice found, and then we need to stop the suspected drug, and and monitor the patient's condition. So if there is no improvement, then it means that the drug that you have that you suspected is not likely to cause this jaundice. Whereas if there is an improvement seen after the stopping of the medication, then there is a likelihood that the suspected drug is causing the jaundice. Then also you have to assess the liver function test, and whenever you establish causality in this patient, you need to do an ADR reporting. And also looking at the causality of the ADR itself, you need to use the scale, for example, Naranjo scale or WHO UMC assessment tool, to look at the causality of the drug with the event. And some of the points that you need to consider is the timing of the reaction versus the exposure, and also pharmacokinetic consideration of the patient, and also based on the literature or evidence. Are there any previous evidence showing that the certain drug is causing the certain types of drug injury? So if there is any previous evidence or literature that indicates that your suspected drug is affecting the liver or causing this liver injury. So lab testing includes AST, ALT, alanine, AST, and ALT. And these are sensitive indicators of necrotic lesions. And serum bilirubin is also a sensitive indicator for hepatic lesions. Serum protein like albumin, transferrin, and prothrombin time. So in terms of the prognosis, when the patient is having a high peak bilirubin level, or if the PT prothrombin time is more than 40 seconds, and then there is an increase in serum creatinine, then the patient is considered to have a low chance of survival. These are the alterations that might occur in the liver enzyme test, for example, for each of the types of DILI. For example, in ALP, it looks like it's more specific to cholestatic type of DILI. AST and ALT elevation may indicate a necrotic type of DILI. It can also indicate a chronic type of hepatotoxicity. So in terms of the monitoring, of course, we need to monitor for the liver enzymes and the symptoms of the patient. And for AST and ALP, we have to monitor every 4 weeks depending on the reaction characteristics. For methotrexate injury after 2 weeks or months, we need to monitor every 4 weeks. For chlorpromazine, if the onset within the first 4 weeks of initiation, we want to monitor even more frequently. And liver biopsy is needed when the patient is on chronic treatment of a certain medication. And jaundice is also one of the most easiest parameter to monitor. So the example of the case, Miss B, 43-year-old with type 2 diabetes, was commenced on simvastatin 10 mg at night 4 months ago. So no other relevant past medical history, and the patient does not drink alcohol and does not consume grapefruit. So past medication history includes gliclazide, MR, and aspirin. So a routine blood test revealed an increase in ALT from baseline before the initiation of simvastatin to 197. So what actually causing this increase in ALT in this patient? So the most likely cause of the increase in ALT is the introduction of simvastatin 4 months previously. So all statins are reported to cause elevations in transaminases, which may be transient or persistent. And if the patient is asymptomatic, we need to repeat the level if ALT 3 times greater than normal. But if it's still high, continue with a full liver investigation. And the therapy might also be changed to pravastatin. So these are the references that I use for this lecture. Thank you very much for your attention.